This conference will now be recorded.
Very good morning. Most probably the last theory lecture of this season. Today we are talking about the viral hepatitis. I'm supposed to speak hepatitis. So we'll come and Sorry, actually, the mic. Now, what I was telling is the viruses causing hepatitis is broadly grouped into hepatotrophic viruses, non-hepatotrophic viruses. Hepatotrophic viruses are specifically causing liver pathology. So these are A, B, C, D, E of them. Only D is a DNA virus. All other R viruses are RNA viruses, of which D is a subviral one because it's not even a complete virus. So this is about the hepatotrophic viruses. Now, speaking about the non-hepatotropic systemic viruses, they can cause hepatic pathology. Example, herpes simplex, Epstein-Barr virus, adenovirus, varicella zoster, cytomegalovirus, HIV, all these can cause. And lately, there is a potentially hepatotropic, not, they not yet finalized it. Examples are hepatitis G virus, TT virus, SEN virus. Very little is known about these three things, but they are mentioned in your textbook. Just remember, they are potentially hepatotrophic, but as on today, there is no disease was diagnosed based. So these are the general structure. Suppose which are all the viruses cause hepatitis means these are the things you must mention in the examination. Next. So this is a general outline of all these five viruses because all in a nutshell why I put in one single table is very easy to you need not remember exactly actually just the incubation period 3 and 4. So because these are common for all these viruses I put in a single table. Incubation period is less for the hepatitis A, 10 to 50 days. Where this ends, hepatitis B starts because after 50 days we said, and then 60 to 180 is the next. Easy to remember. So where the hepatitis A ends, hepatitis B incubation starts approximately. This is 50, just give or take 10 later. C is almost like hepatitis A, but only thing is the duration, the range is high, much larger ones. The range is like B, but beginning is like with the hepatitis A. And D and E are almost like hepatitis A, 20 to 40, 20 to 60. Triple A, you need not exact figures, not necessary. They are almost like only prolonged incubation period are with B and C, whereas C has a wide range, B is a lesser range, 60 to 80, 2 to 3 months. So this is about the incubation period in a nutshell you can remember. Regarding the transmission, so B and C are parentally transmitted. The B and C are parentally transmitted. D also just like B. For all practical purposes, it doesn't have a this thing. So only thing is E is definitely not parental. It's only oral. There is no parental transmission. Emma? Hello? So hepatitis A, because I put a dash because the possibility of transmission, but usually it's our oropharyngeal route, echo-oral route. There is sometimes technically it is possible to transmit. That's why I put a dash. Now fecal oral transmission, definitely A and E. Other three, they do not have fecal oral transmission. So A and E transmission and duration almost similar. Now when vertical transmission, perinatal transmission is there, it is possible with B and D. B and D are almost similar transmission. C technically correct, but not known at all. So A and E are not transmitted. Hello? Will you please mute all of you? Okay, thank you. So chronicity of infection. The chronicity is present in the central three, these three, whereas A and E, they do not have the chronicity. And hepatitis is known to occur D and C and B. whereas A and C are not known to produce fulminant hepatitis. These are the commonalities. There is some similarities between these things. So initially it looks a little difficult, but if you just go through, understand, it's not that difficult. But in a nutshell, for you to understand better. Now, how is the pathogenesis of this? Well, look at the pathogenesis. It is a direct cytopathic because hepatotrophic viruses, I told you. So, immune-mediated injury involving the entire liver, leading to necrosis, and necrosis is more marked in the centrilobular areas, the centrilobular necrosis. Then there is a necrosis, mixed inflammatory infiltrate, especially the portal areas, and there is a proliferation of the bile ducts, okay, bile duct proliferation. Kupffer cells, this is a reticular endothelial cells, hyperplasia in the sinusoids. So this hypertrophy produces obstruction to the calculi. So that's why there is a cholestasis can occur. But whatever has occurred, usual pathology is they all return to normal in a case 3 to 6 months. Usual, there is normal pathology unless it goes into chronicity. Only when it goes to chronic hepatitis, the periportal infiltrate continue to grow and ultimately lead to what is called the scarring, that is cirrhosis. Only in case of chronic. Otherwise, total resolution in the case of 3 months maximum. So this is the general progression of pathophysiology. Now the biochemical profile of acute infectious disease, let's see. So what happens first and foremost, the rise of serum levels of certain enzyme system. Whenever there is a hepatic damage, you suspect liver enzymes elevation. So alanine aminotransfer, ALT and AST, aspartate aminotransfer is elevation, and also bilirubin elevation, especially because the one is hepatotoxicity and also cholestasis. Both contribute to a mixed type of hyperbilirubinemia happen, conjugated and conjugated together. And cholestasis specifically I am mentioning because the abnormal bile flow at the canalicular and cellular level because of the hepatocyte damage and inflammatory mediators, they're all causing the obstruction. So in addition to this elevation of serum bilirubin, there is evidence of cholestasis is manifested by the element of separate enzymes like alkaline phosphatase, 5-nucleotidase, gamma glutamyl transpeptidase levels. So whenever these enzymes elevated, that indicates cholestasis, whereas ALT and AST elevation indicate liver damage, cell damage. The third one is altered synthetic function. So liver synthetic function elevated. What happened? The protein synthesis is affected. So then there is a prolonged prothrombin time because of prothrombin production diminished. High INR ratio because the PT whenever the PT is prolonged, INR also elevated. And albumin levels or hypoalbuminemia develops, especially in the cirrhosis condition. If you are familiar with the ascites and all these things. Other metabolic disturbances you expected is hypoglycemia, lactic acidosis, hyperammonemia, all these things, metabolic abnormalities because of the liver function failure. When there is a poor clearance of medications or the liver dependent function, there is especially if you have drugs and all these things, they don't get cleared. We must be careful about the hepatic metabolized drugs. And once hepatic encephalopathy ensures, there is altered sensorium with the increase in deep tendon reflexes and typical of a cerebral damage. So these are the biochemical profiles and habits. Now, coming to the specificities. Hepatitis A, we'll start with individual level, we'll deal with all the hepatitis A. It is a small non-enveloped RNA virus, picorna family. The sporadic is especially it's a commonest cause for the sporadic hepatitis. 60 to 70% of hepatitis in India is hepatitis A. And usual mode of transmission is orofocal, fecal-oral route, and the duration of illness is hardly 1 week. No chronicity, and acute liver failure is very, very less common. So look at this actually, each tumor, the development is the incubation period is 10 to 50 days, and average you can say as a 30 days. It has 3 phases. First and foremost, the prodromal phase lasts around 7 days. At this stage, the symptomatology are fever, loss of appetite, diarrhea, and dark urine because of the bilirubin elevation. Usually bilirubin about 2 to 4 milligrams, not high. There's a nausea and vomiting and the pale stools because the cholestasis. These are the symptomatology initial. Then comes the icteric phase, okay, where the deep jaundice a little deepens, nearly about 2 to 4 milligrams. And elevated liver enzymes at this stage, you see. By this time, the fever subsides. And last is a convalescent phase. That means that after this first 1 week or 10 days, it is a recovery phase. It lasts about few weeks. It slowly recovers actually, but ultimately it's a complete recovery happens. But please remember, some cases, only 0.1 to 1% maximum, may end in pulmonary hepatitis with hepatic encephalopathy. It's very rare. Hepatitis A, it's very rare, but there is a technical possibility is there. Just remember that. See, whenever any infection is asked, remember to put this test, whether it is enteric fever, it is hepatitis, or is it dengue fever, all these things, because in the examination, the examiner understands instead of writing paragraphs and theory, if you draw this, that means your knowledge, you are exposing your knowledge that you do know things at all. So all these things is you just have to understand. It's not these difficult graphs at all. See, on a y-axis is the degree of the elevations. On the x-axis here we are showing the months, number of months. The only thing is pointing. Just remember how to understand, because you said hepatitis C incubation period is about 30, average 30 days, we said 1 month. So 20 to 40 days, the 1 month is here. So somewhere we are here actually. This is the in between this area. The incubation period means at that time the symptoms start. Actually, see, the line is coming before 1 month. So what is jaundice and symptoms of like nausea, vomiting, and fever, all these things start. But before this enzymes, the symptomatology has started, this elevation of the enzyme systems, alanine aminotransferase, there's GOT, because it elevates, and by the time the symptoms develop, it starts flattening and gradually returns to basic level of the 5 to 6 months. That is one thing. But before the symptoms are manifest, HIV, you can see in the stool. HIV is shown in the stool itself, even before that is within 10 days of the infection also. But at this stage, the symptoms, there are no symptoms, but it is excreted in the stool. That means the patient is infective to others. That's only understand. Because even before the symptom keep on eliminating the stool, it is there in the stool means it can transmit to others. So that is that's why you have to start this graph a little earlier than the before the incubation. Then what happens body reacts with the development of anti-HIV hepatitis C antibodies. So antibodies are two types, all of you are familiar. IgM starts and IgG almost starting and immediately, but only thing is IgM levels are gradually retaining. You see that by the age of 8 to 10 months. So elevated, gradually coming down, at all taking about 8 to 9 months. Whereas IgG levels, they go on starting and they remain persist. So this is actually anti-infective and anti-hepatitis C virus. These are IgGs. So that means they persist here. Now only one thing we left off is anything? Yeah, everything. IgM we have shown, IgG and enzyme systems and jaundice and all this. Usually they last about maximum 3 months. So by 3 months anything entire is clear. So all three phases, phasic phase, and convalescent phase, all together, these are the phases, 3 phases together, 1, 2, and 3. So all 3 phases are, we have covered in the previous slide I mentioned. 1, 2, and 3 phases. And this is all the recovery. If you understand, it becomes very easy in the diagram. Now, what is the treatment? Is there any treatment for hepatitis? Because all these medications, all the Ayurvedic medication, there are the liver support are all nonsense, because hepatitis A is a self-limiting disease. The only thing is maintain the adequate nutrition. What they do is, patyam, they say actually, patient is having low appetite and they starve the patient. You should not eat that, you should not eat this. All these things is nonsense. Eggs, milk, butter actually help provide the correct caloric intake. It's not, don't give fats and all these things. It's all nonsense. Antiviral agents have no role at all, no drugs. They do not work on the hepatitis A. Steroids are sometimes indicated in patients with cholestasis and relapsing hepatitis, not routinely. Please remember, routinely you don't give any steroids. If If there is a relapsing hepatitis and where the cholestasis is extensive, such times you may think of oral steroids. Otherwise, not indicated. Only thing is adequate nutrition, hydration, and supportive therapy. Rest and this thing. There is there even paracetamol you have to be careful because of the hepatic damage. So only symptomatic treatment. That's all. But this is a very important. Hepatitis C can be prevented. There is a even before exposure, this pre-exposure and post-exposure, they may ask separately in the short notes. So what is pre-exposure prophylaxis? Even before you, that means you are traveling to an area where it is known that hepatitis C is endemic. So you want to take precaution, especially your colleagues, your nephews and relatives coming from the USA. You can advise them to suppose that they are coming to India. India is the endemic area. So if they are coming, this is the best thing they can do is if a child is less than 1 year, immunoglobulin, these doses are 0.202 ml per kg. If it is 3 to 5 months, 0.06 ml. Above 5 months, 0.065 ml. Only thing is, if you are staying for more than 5 months, long stay, every 5 months you have to give. There is immunoglobulin. It's a normal immunoglobulin IgG. There is no specific anti-hepatitis C immunoglobulin at all in the world. Suppose the child is above 1 year and healthy child, all they require, don't require, just give hepatitis C vaccine. There is an active immunization and bring the child, that's all. But if the child is immunocompromised or having a chronic liver disease, don't just depend on active immunization because we do not know how far it is effective. So active plus passive. Hepatitis C vaccine also you give and immunization per kg. So this is the precautions. This is called as a pre-exposure prophylaxis depending upon the ages. Now, hepatitis C can be prevented even after exposure. This is called the post-exposure prophylaxis. Only again here what is there? The passive immunization you can do immunoglobulin IgG. So if it is less than 1 year, as I told, 0.02 ml per kg intramuscular. For immunocompromised child and chronic liver disease, along with this, you give hepatitis C vaccine also. The child is more than 1 year, hepatitis C vaccine alone is sufficient, even after exposure. The only thing is, within 2 weeks of exposure, you have to give, because if you give this vaccine after 2 years, that means you accidentally you got exposed to the patient. And after, if you remember, before 2 weeks, if you give the hepatitis C vaccine, yes, it is still effective because the vaccine incubation period is faster than the infection virus. Okay. So what are the vaccines available? There are two vaccines available in India. One is inactivated vaccine, Havrix, it is called as GSK's, 0.5 ml intramuscular deltoid, 2 doses at 6 months interval, 6 months to 1 year of age. There is another live vaccine which is also available. It is a single dose is available. This is called BioVac A. In India, it's available. It is a H2 strain vaccine. They are both are equally good, they say. Only thing is, killed vaccine requires 2 doses. Live vaccine only 1 dose. That's it. 2 vaccines are available as on today. Now come to the hepatitis B vaccine. This is the rough structure of the very simplified structure I've been showing, because here hepatitis vaccine very important, because as you know, this is called as the Dane particle. The central virion is called as the 42 nanometer size, and it is called as the Dane particle. Dane particle. It is belongs to hepatinovirus family. It's a double-stranded DNA. All other hepatitis viruses are RNA. This is a DNA genome. And 8 genome types are there, hepatitis A and H. Okay. Now 4 consecutive genes. This is a 4 genes are seen. One is surface. So second is a core antigen gene. One is X and P polymer genes are there. So each gene is responsible for some protein. One is transcriptions and activities and separately. So if you look at the structure of this, the most of the replication in the liver and some other tissues also sometimes infected, like lymph nodes, spleen, and kidney and pancreas also involved. Just look at this structure once. Actually, this is a surface antigen. This one on the surface you can see there are 3 types of them: medium, small, and large subtype. The surface antigens are actually, there are subunit systems are there. So This because this is, and now the hepatitis A B virus and vaccine is against the using these subunits. That's why it is important. And there is a core antigen inside. There is a green one. You see the core antigen is there. This is also core antigen. And inside you can see double-stranded DNA vaccine, and there is a polymerase. This is a DNA polymerase part of this DNA. And in between there is a non-structural protein. This is not a structure, it is a secret liquid part. Here is some dots you see here. This is hepatitis E antigen. This is a NS protein, non-structural protein it is called as. That is also important because the presence of HBe antigen serves as a marker of active replication, because E antigen is not always there. But wherever there is a E antigen is there, such diseases is there actually troublesome. Either they go for chronicity or they go to the severity. Actually, the active viral replication is there. Infectivity is also very high such people. So that is the importance of E antigen. It is a non-structural because it is not attached to the structure anyways. So that's all. It is a simple structure. You can draw in the examination also if you understand very easy. That's why I put a line diagram. Always remember the line diagrams. Now, this is the global prevalence of hepatitis B. Why it's important is, you can see the buff colored, actually anything above 2%, this is a 2% is the limit actually. You can see anything less than 2% population are having hepatitis B surface antigen HPSAG low prevalent areas, and above 2. India comes into 2 to 4%, low intermediate actually. So here it is a mild buff color, this mild buff color, low intermediate zone. The reason is all those conditions above 2% incidence is there, is prevalence is there. Such can require universal precaution against hepatitis B surface. That's why all these countries where there is a above 2%, they follow universal immunization of all the children born immediately after birth. They give hepatitis B surface the vaccine. So that is an intermediate zone. India comes under intermediate, low intermediate actually. Now, how is it transmitted? Now that is vertical. Vertical transmission from mother to child. Mother to child is risk is greatest if the mother is also HBe antigen positive. As I said, it is a non-structural protein. If at all, then just like the severity, the transmissibility is also very high when there is HBe antigen is positive. So mother to child transmission is a known, it doesn't transmit by breastfeeding. The other one is a horizontal transmission. Is horizontal transmission from one person to other, either because of the blood transfusion is the oldest method. Sexual transmission is possible from the partners, and the infected shops, especially the drug users and all these things, and the accidental exposure, whatever the professionals. Body fluid contamination of the wounds. If you've got an open wound and some secretions have fallen onto that, blood products and the product part than that. So because the infective dose is much smaller than the HIV, 0.401 ml is enough. Very highly infective than hepatitis B. More infective than the HIV. But only thing is, God saved, breastfeeding does not transmit hepatitis B. That is the only thing is. So the two modes of transmissions, you remember, parenteral and there is no enteral transmission for this, only vertical and horizontal. Coming to the clinical features, the incubation period is roughly, you can say 60, because we said 60 to 180 days, but you can say 6 weeks to 6 months is very easy to remember. It may be acute presentation, chronic and fulminant. All three varieties possibilities are there. Acute hepatitis are symptoms almost similar to hepatitis. The only thing is, just like fever, vomiting, jaundice, anorexia, but majority of the times it is called as anicteric hepatitis. That most of the jaundice is very mild, or it may not be there also. So it's called as a anicteric hepatitis most of the times. And in addition to this common symptomatology, it also has extrahepatic manifestations like arthralgia, rashes, especially the Guillain-Barré syndrome. It's causes specific rashes on the blisters of the skin on the legs, buttocks, and arms. Papillary acrodermatitis is another skin manifestation. Polyarteritis, glomerulonephritis, gastric anemia. These are the non-hepatic manifestations of the hepatitis B manifestations. So you will see in the complications also this one again. So what happens, the natural history, what happens after the hepatitis? First acute infection has come, then it may go to chronic, it may go to cirrhosis, and even the liver cells. So after acute infection, what happens? 90 to 94% they resolve. But some percent, 5 to 10%, they go into chronic carrier stage. So what determines chronicity? Again, I will see in the next slide. So after going to chronic hepatitis, again, it may stabilize or it may go to progression to in next stages again. Next stage is cirrhosis. Cirrhosis again get may compensated, but or it may be decompensated, leading to death because of the complications of cirrhosis, borderline hypertension, all these things. And ultimately, it may want to liver cancer, hepatocellular carcinoma, and after carcinoma, the only result is death only. So this is the total progression of the hepatitis B natural history. So when I'm talking about the chronic caricity, what determines chronicity is actually adult, it is 10%, because when you got infection, that determines mostly. So if a person, adult got infected, the chances of chronicity are less, 10% only. If children are infected, the chances of chronicity 20%. If it is a vertical transmission, mother to child transmission, definitely 90% of such people become the chronic carriers actually. That's remember. So the longer the duration it is in the body, the greater the chronicity chances are there. That is it. Again, as I said, for all these hepatitis infections, the line diagrams are very, very important. Just remember here. As I said, the incubation period is long here actually from 1 month. Here it is shown nearly 1 month to it is showing after 2.5 months. As it may variable, there is the incubation period you can see. Then the prodromal phase is the one because from that phase actually where there is a symptoms may have been early, late convalescence. Convalescence again divided into two phases here actually. So what happens during these phases are, as soon as this 1 month actually, when the DNA polymerase DNA particles are visible within 1 month actually. Once it's entered, 1 month onwards, we can see the DNA particles. Along with this, you can see, so the infectivity starts in. Then HB surface antigen and E antigen. If the E antigen is there, it will start earlier and followed by surface antigen elevation. But the E antigen titers are very, very low and disappear within 4 months. Whereas HB surface antigen antibodies, they rise, this is again IgG, and they persist like this. So surface antigen appearance, almost like along with the DNA particles, its appearance comes here. So surface antigen first, and then B antigen next appear, then antibodies to surface antigen, and antibodies to B antigen, very, very late in the development. So two antigens and two antibodies, remember. In between, there is called as a window period, actually, when there is a quiescent period. There is no antigens and no antibodies also, except for the HBs, anti-HB core antibodies may be seen. So anti-HBs are latest to develop and they persist. So this is the core antigen antibodies, antibodies to core antigen, please remember. So these are the general serological structure, and in a separate table I will explain this understanding of this actually. So this is very, very important table for you, interpretation of the results. Suppose you did some labs, because only sometimes they ask only interpretation of the hepatitis B serology. So what are all the possibilities actually? Here we have taken two antigens, HBs, HBe, because the core antigen is not possible to diagnose in the body at all. Only HBe antigen you can check it, only surface antigen you can check in the serology. C antigen it is there, but you cannot take in the serologically. That's why it's not there. Then two antibodies. One is the anti-HBe, and sorry, one is anti-HBc, anti-HBs. There are three antibodies. This is the polymerase chain reaction, PCR DNA antibodies. These are the things. So in a chain where the DNA particles are there, HB surface antigen is there, B antigen may be positive or negative. So such condition, we call it as a, what do you call this? Sorry. Early hepatitis, acute hepatitis, or a persistent carrier. S antigen and core antigen also, antibodies for the core antigen, HB anti-HBc are present. Such is called the acute hepatitis. IgM is persistent carrier, and chronic hepatitis anti-HBC IgG is in the carriers. If it is only IgM means acute hepatitis. If it is anti-HBC also is there in the form of IgG, either is a carrier or a chronic hepatitis. That's because IgM is only for acute manifestations. And the most then important recovery phase, you can see when there is an anti-HBs antibodies are there, these are actually protective. So such patients is the recovery phase. And all three antibodies, HBE antibodies, HBC antibody, and THS antibody is there, but negative for the virus, negative for the antigens. That means the patient has recovered. So if none of them are positive, only anti-HBs is positive. So such patient is called as an immune. He is actually, this can happen even with vaccination also. The titers should be about 20 international units per ml. So such is only anti-HBs antibodies positive. Such patient is an immune. This is from the Frederick Suchi. This table better to understand everybody. So this is again a clear explanation for this. Somebody HP surface antigen positive, the first marker to appear in the blood after the infection. Then HBs antibodies, that is antibodies to this particular HBs antigen. So disappearance of the HBs antigen and appearance of anti-HBs signals a recovery from the hepatitis B infection and non-infectivity. So this is the understanding of this. Suppose anti-HBC core antigen antibodies are there, if it is IgM only here. So shortly after HBs is detected, HBM IgC also can persist for 3 to 6 months or longer. After that it disappears. Whereas IgG antibodies appear during the acute phase but persist indefinitely. That is a good. What about HBE antigen? It is concurrently with HBs antigen. It may appear only in HBE antipositive serum, not always. But if it's present, indicates viral replication and high infectivity. And if it persists beyond 3 months, there is an increased likelihood of a chronic hepatitis. It should disappear before 3 months. Persistence of a HBE antigen is a very, very bad sign. So these are the things in a nutshell you have to understand. What complications can occur hepatitis B? As you said, acute liver failure can happen with the coagulopathy, encephalopathy, and cerebral edema. It may lead to chronic hepatitis, as in the case of cirrhosis and end-stage liver disease and hepatocellular carcinoma. And extra that is hepatic manifestation like membranous glomerulonephritis. So this delivers deposition of the complement-based HBE in the glomerular capillary. There is membranous proliferative glomerulonephritis. All of you familiar with this nephrotic syndrome type of presentation post-viral infection. It is notorious for the hepatitis B surface. So this is a complement is diminished in these conditions. So these are the extra all the complications, the notable complications of hepatitis B. Then, what is the treatment again? There is no treatment. Actually, acute hepatitis B is largely supportive, whereas chronic hepatitis B, you can try to reduce the viral replication, having undetectable hepatitis B DNA particles and the serum and development of anti-HBE antibodies. That is the purpose. For this, there are some drugs have now been given. This is pharmacotherapy, hepatitis B, for the immunely active form of there is a chronic active hepatitis and chronic hepatitis conditions when there still is immunity is active is there. So notable is pegylated interferon alpha 2. Pegylated is actually it is low sustained release interferon A alpha. It can be given subcutaneously once in a week. And other drugs which inhibit the viral replication because DNA polymerase antagonist actually. These are one. Telbubidine, lamivudine. Lamivudine, all of you are familiar with the HIV management. These are the only synthetic nucleoside analogs. Adafovir is a purine analog. Entecavir is again nucleoside analog. Tenofovir is a nucleotide analog. So this, in terms of the terminologies, you might have seen HIV management. This can be used now with the reduction of the viral load of hepatitis B, chronic active hepatitis B. But the prevention is very, very important. All of you are know the strategies for prevention is screening of all pregnant women for hepatitis surface antigen. That itself is any positive. You have to check for the DNA virus. If somebody is positive, DNA titers, how much of the viral load is there. If the DNA load is more than 200 international units per ml, then you can immunize that, and there is a suggestion with the maternal antiviral therapy. You can treat mother itself. You can start with because vertical transmission you can prevent it. Then after birth, prophylaxis hepatitis B surface hepatitis B immunoglobulin for infants born hepatitis B surface antigen positive mothers. How you will give dosage schedule I will give later on. And the last strategy is the universal immunization of all infants beginning at birth itself, and routine immunization of those people who missed at birth also you can give below 19 years of children. All children must receive hepatitis B surface, the vaccine. The schedules here actually, if the mother is HbS age negative and the child is about 2 kgs, usually below 2 kgs we are waiting. Hepatitis B vaccine is not advisable, at least wait until 2 kgs. That's the usual recommendation, IAP recommendation. So at birth you give 1 dose and within 12 hours ideally. Second between 1 to 2 months, and third before 6 months. Actually now we have mixed with the polyvalent vaccine, is a pentavalent vaccine. It's mixed with that now, so that 6 weeks, 4 weeks, and 6 weeks, 10 weeks, and 14 weeks. There is it, along with the DPT and other things now. So otherwise, these are the maximum. Before 6 months, you must complete 3 doses. The only difference is, if suppose the mother is HbSAg positive, all 3 doses are same. Only in addition, we give within 12 hours. Ideally, you have to give along with that HB anti-immunoglobulin, HBIg, passive immunization. On one leg, you give active immunization, and the second leg, you give passive immunization. So you may get some. Is it possible to give active and passive at a time? Don't they each neutralize each other like that? You may not, nothing to worry. You give them the separate limb. One thigh you give hepatitis B vaccine, and the other thigh you give hepatitis B immunoglobulin, right? Preferably simultaneously. Okay. And the second and third dose, just like the previous, along with the pentavalent vaccine, or before 6 months, 2 doses. For children who are not, if somebody come, there are different schedules are given. 0 after 1 month and after 6 months, that is the usual adolescent vaccine, or 0, 1 month, 2 months, and again to boost it 12 months. So these are the 2 schedules, and there is different schedules are also there. Adolescents 0, 1, 6 months, 0, 12, and 24 months adults. So these are the different schedules. All schedules are acceptable. As on today, there is no booster vaccine. Booster doses are not advisable routinely. Only boosters are necessary for those people who are professionally exposed, especially those people who are handling the serum products and the blood banks and all these things, or in veterinary practices such ways where they are exposed to the blood products mostly. So such cases only they can check their antibody titers, anti-HbS antibody titers. If the titers are below 20 international unit, then only their booster dose is applicable. Otherwise, routinely hepatitis B booster is not necessary. Please remember that. Coming to the hepatitis C, is a single-stranded RNA virus belonging to the Hepativirus of a flaviviridae family. The genotypes 1 and 2 are most prevalent, but in India, the type 3 is most common, especially in Australia and subcontinent, the type 3 is common. Worldwide prevalence is about 3%. Mode of transmission is either vertical or parental. There is no oral transmission at all. And please remember, it doesn't spread through bloodstream. Clinically, 85% of the patient exposed to hepatitis C develop chronic infection. That is the most dangerousness of this thing. 10 to 20% develop cirrhosis and some hepatocellular carcinoma possibilities. The prognosis in childhood hepatitis C vaccine, unlike in adults, it is very, very good actually, because hepatitis C in adults is much more dangerous. Significant percentage, nearly 40% of the vertically infected children simultaneously clear hepatitis C virus in a few years. Even if when the mother is transmitted to the baby, maximum few years they virus free. So that is a good thing for children. Treatment, again, pegylated interferon 2 alpha 2b, and ribavirin. These are both drugs that are approved by FDA. In children above 3 years, all these are approved for chronic hepatitis C. Acute, no need for any treatment. Other drug which is again sofovivir is again antiviral drug in combination with the ledipsavir. These are approved for adults, whereas if it is type 2 and 3, sofosbuvir with ribavirin. These are the two combinations approved by the FDA. So if you remember this, all this thing, pegylated interferon is commonly used. Remember that one. Hepatitis D is the smallest known animal virus. It is considered as a defective virus actually because it cannot produce infection without a concurrent B infection. It always is a satellite of hepatitis B. Single stranded circular RNA that expresses the hepatitis B antigen. HDV can cause infection at the same time as initial hepatitis B virus infection, then it's called as a co-infection. Or HDV can infect a person who is already having with hepatitis B, it's called as a superinfection. So the pathology of the hepatitis D is described in these two terms. One is a co-infection, the second is a superinfection. That you have to remember here. So symptoms almost similar to hepatitis B and severity, but usually more severe. If the D is also positive, the symptoms are much more severe. If it is a co-infection, acute infection, which is much more severe than the hepatitis B alone. If it is super infection, acute illness is rare, but chronic hepatitis is common. So the risk of acute liver failure is highest in super infections, and subsequently patient develops hepatitis D also. Whenever hepatitis D should be considered, any child who experiences acute liver failure. So please remember, it most probably it is a D also is there. The treatment is magically to control the hepatitis B virus infection, without which HDV cannot exist. So if you treat the hepatitis B, there is a treatment of hepatitis D also. Immunization against hepatitis B is a prevention against hepatitis D also, because it does separately exist. Hepatitis B vaccine and HBIG are used in the same indication as in the case of hepatitis B alone infection. So separately, there is no preventive strategy for hepatitis D. Then comes hepatitis E. It is also a single-stranded RNA viruses. It's non-enveloped viruses. Epidemic form is what was formerly known as non-A, non-B hepatitis. Is a enterally transmitted, fecal and waterborne most often. The mean incubation period is around 40 days. And the clinical picture exactly almost resembles hepatitis A. Chronic illness is not known with hepatitis E. The only problem is when the pregnant woman, if it gets hepatitis E, the result is very, very bad. The chances of acute liver failure and high fatality rate. So if a pregnant woman gets hepatitis E, the mortality of the mother is very, very high. Hepatitis E can also lead to decompensation of the pre-existing chronic liver disease. Suppose if somebody is having chronic liver disease, cirrhosis, or some other reason, whatever it is, in such patients, if the hepatitis E infection happens, the mortality or the severity is very, very bad. Treatment is symptomatic and supportive. Ribavirin therapy in patients with the fulminant hepatitis and pregnant women has been suggested. The prevention is mainly the prevention of a infection. There is a hygiene, personal hygiene, surrounding hygiene, including food, water, personal disposals, and all these things actually. So there is no separate vaccine available for this. A word about hepatitis G. Hepatitis GB virus C, it's called as a HPGV. It's a flaviviridae group, member of the PEG virus gene, and it does infect humans, but as far as still today, there is no disease been described. Actually, infection might have occurred, but it's a subclinical. It doesn't manifest any disease at all. It is called as a orphan virus. That means virus still in search of a disease. Because such can say, just like orphan children without any parents, like this virus is there, but there is no disease related to it. So when you get a suspicion, after E, why there is G has come, what happened to F? There is several attempts were made to make hepatitis F is a hypothetical virus as under several hepatitis F candidates are emerged in 1990s, but none of them claim to be substantiated. So they left F as a possibilities, but G already they have identified, but there is no disease identified with hepatitis G in human being. So that's all. All of you just remember to all of you, 28th of July is celebrated as a hepatitis World Hepatitis Day every year. So with that, thank you very much. Thanks a lot. So okay guys, with this I stop.